What I've been asked to speak about today is about immigration, detention, and child health. And I'm not employed by WHO, but I have worked with WHO European region for a number of years now, and they've asked me to come along and speak on behalf of WHO on this occasion. But as you can see from the logos at the bottom of this slide, I have a number of other affiliations, and I'm primarily a researcher working at Australian universities. So just quickly to give some context to the comments that I will make, my background is in forensic psychology. I completed a PhD in forensic psychology a number of years ago, and I've been doing research in the public health area for about 25 years now, which is an indication of how old I am. I am not a legal expert, and so I'm just looking at the program from yesterday and today. There is clearly a lot of legal expertise in this group already. My expertise is in health, and particularly in the health of people who experience deprivation of liberty. Some of the hats that I wear in Australia, I'm the founding chair of our National Youth Justice Health Advisory Group, which is thinking about how to monitor the health of children in detention. I have, over the years, worked with a variety of UN and other international agencies, including WHO, UNICEF, UNODC, the International Committee of the Red Cross, and others. I'm a member of the WHO Health in Prisons Program Steering Group, and it's in that capacity that I'm here today. And also a member of the Steering Committee for WEFRN, the Worldwide Prison Health Research and Engagement Network. And perhaps most relevant to today's presentation, my group also led the health chapter, the health theme, in the UN Global Study on Children Deprived of Liberty, which you may have already heard of. If not, I'll be sharing some key findings and recommendations from that. So you might find that my presentation is a little bit repetitive, and that's intentional. So what I'm going to do is cover some of the key evidence and some of the key recommendations regarding the health of children in immigration detention. And not surprisingly and pleasingly, the different groups have very similar recommendations, and hopefully by presenting recommendations from a few different entities and seeing how similar they are, that will reinforce the strength of those recommendations. So I did just have a look at the most recent numbers of the number of children in immigration detention in Poland. These are numbers from 2021. I imagine you may have already discussed these numbers during yesterday's training. I'm aware that there's only one centre, which I won't try to pronounce, in which unaccompanied minors are held. I think there are 15 beds for unaccompanied minors in that particular centre, but during 2021, there were 81 unaccompanied minors in there. And as you can see, quite a few hundred children in immigration detention in Poland at some point in 2021. This is a terrific implementation guide produced by WHO that I would encourage you to have a read of if you haven't done so yet. I am going to summarize this and a number of other quite large documents. So I promise not to go into all of the details, but what I want to try to do is draw out some of the key points from these various documents. So this implementation guide is about addressing some of the health challenges in immigration detention, and particularly thinking about some alternatives to detention. And what I want to do is just pull out this information. This is a summary of evidence from a combination of a review of the published evidence, both in the academic literature and in technical reports, in grey literature, coupled with consultations with people in immigration detention. And it's a summary of what are thought to be some of the key health issues experienced by people in immigration detention, broken up into some different categories. Overall health, we find that people typically report low quality of life, health-related quality of life in immigration detention, and that in the view of many people in immigration detention, a key driver of their poor quality of life is the detention environment. It makes sense, of course, that most people don't wish to be detained against their will, so that's not surprising. One of the important considerations from a public health perspective is that typically, compared with the surrounding communities, people in immigration detention will have a higher prevalence of communicable diseases, including but not limited to HIV and tuberculosis. And this is, in fact, no different to what we see in other places where people are deprived of liberty, including, for example, prisons, where again, we know that people deprived of liberty in those settings have a higher prevalence of communicable disease than do people in the surrounding communities. The problem is, of course, that firstly, we're therefore concentrating communicable diseases in those settings. And secondly, those settings are very high-risk settings for the spread of communicable disease, often overcrowded, often with unsanitary conditions, poor ventilation, poor nutrition. So it's a bit of a perfect storm where firstly, in places of detention, immigration detention and prisons, we concentrate people with a higher prevalence of communicable disease. And then secondly, we create an environment that increases the risk of spread of those diseases. As you saw from the previous slide, most people spend only a few months in immigration detention. So this is not just an issue for people in immigration detention or for the staff working in those settings for that matter. It's also an important public health concern for the surrounding communities to which people return after release from immigration detention. We know less about the prevalence of non-communicable diseases, asthma, cancer, diabetes, and so on. But we do know that in immigration detention, there's often an increased prevalence of injuries and related traumatic events, often related to experiences that led to someone seeking asylum or migrating to another country. With respect to healthcare, and I'll talk a bit more about this later on, there's a few key issues that we need to consider. The first is that there's often a lack of trust. People in immigration detention may have left circumstances where there is low trust for authorities. And so it's often difficult for healthcare workers in immigration detention to gain the trust of people in those settings, even if they have the best of intentions. That's compounded by communication barriers, and that can be obviously as simple as language barriers. It can also be barriers around culture and appropriate ways of communicating with different people. So there's a concern with respect to healthcare in immigration detention. And again, there's a striking parallel with prisons, where immigration staff who are responsible for the security of immigration detention often serve as gatekeepers to healthcare. In other words, unlike in the community where somebody can go directly to a healthcare provider, in immigration detention and in other places where people are deprived of liberty, they often need to go through immigration staff. And so that raises some really important questions about how well trained those staff are to make decisions about somebody's need for healthcare. And of course, there's also issues around the availability of healthcare providers in those settings, whether they're employed by immigration detention or employed by an external provider. One of the key health issues that I'll focus on today is mental health. And I'm sure many of you are aware that the detention environment, firstly, again, like with communicable diseases, concentrates people with poor mental health. And then, and I'll speak about this more soon, there's evidence that the detention environment compounds those mental health problems, makes them even worse. So already a high prevalence of mental health problems coming into detention, and then the detention setting can compound those mental health problems. In the data that we have, and the data are far from perfect, the most common mental health problems are depression and anxiety, which are the most common mental health issues in our communities as well, and also post-traumatic stress disorder, obviously related to traumatic experiences that people may have had before or during their migration. So what we do know when we compare the mental health of people in immigration detention to the mental health of people in prison is that the rates of mental health problems in immigration detention are similar to or higher than the rates that we see in prisons. Why is that comparison useful? Well, we know that in many parts of the world, there's been a deinstitutionalization movement, so closing of inpatient psychiatric facilities, mental health facilities. And what we've seen is a shift of people with serious and untreated mental health problems into prisons, to the point where they're often described as the new asylums. And so what we see in immigration detention is similar or possibly even higher rates of mental health problems among people detained in those settings. We also know, and I'll speak more about this in a moment, that the longer people spend in immigration detention, the worse their mental health gets. And thus, there's a very strong recommendation to minimise the amount of time that people spend in detention. There are also some key issues to consider with respect to women's and children's health. We know that depression in particular is more prevalent among women than men in immigration detention. We know that the mental health impacts of detention tend to be greater for children than for adults, and I'll come back to that. And critically, from a public health perspective and from a life course perspective, we know that the mental and developmental impacts of immigration detention for children don't stop when they're released from detention. In other words, those mental health and developmental impacts can continue on for many years after a child is released from detention. So what happens in detention is not just an issue for immigration detention, it's an issue for child health in the community going forward. So there have been a number of recommendations, as I said, about what we should do about this problem. I'm just going to quickly cover a couple of the key ones. This is another document that I'd encourage you to read if you're interested in these issues. This is the WHO's Health Evidence Network synthesis report on public health aspects of migrant health. And in recognition of those health issues, WHO has recommended, firstly, removing any restrictions on access to healthcare for asylum seekers and refugees, including people in immigration detention. Secondly, ensuring full health coverage for all children, regardless of immigration status. In other words, noting that children in immigration detention remain entitled to the highest attainable standard of health and providing full health coverage to ensure that that can be achieved. Also recognising that the health of children and adults in detention is not just a matter for the health system, but it's a whole of government, whole of system issue. WHO has recommended coordination between health authorities for immigration detention and other relevant agencies, for example, housing, employment and education, which are also important to the health and well-being of people, particularly once they're released from detention. An obvious concern, and one of the easier ones in some ways to overcome, is language barriers. And WHO makes the point that in addition to, or rather than training immigration staff to be fluent in whatever languages are necessary to communicate appropriately with people in detention, it's probably more realistic, affordable and efficient to have external providers from the community coming in to communicate with and engage with people in detention. And as a researcher, I'm very pleased as well to see that WHO is calling for better data to inform responses. If we don't know what the health needs of people in immigration detention are, it puts us in a very poor position to respond appropriately to those health needs. So some of those recommendations have been echoed in a report by the World Psychiatric Association. A couple of specific recommendations from the World Psychiatric Association with regard to mental health care for migrants. The WPA makes the point that policies must align with human rights, that there must be adequate treatment resources to meet need, noting that the prevalence of mental health problems in detention is considerably higher than in the surrounding community. So therefore, the need for mental health resources will be greater in immigration detention than in the surrounding community. The WPA calls for the importance of cultural competence training to allow for appropriate engagement between mental health providers and people in immigration detention. And again, echoing WHO, calls for a coordinated whole of government response, again, housing, employment, education, and so on. The WPA also recommends thinking about eliminating barriers to help seeking. If a person in immigration detention is experiencing mental health problems, there's often a lot of stigma associated with that. and it's incumbent on authorities to think about what they can do to reduce those barriers around stigma and access. And so WPA is essentially recommending culturally sensitive, accessible, and emotionally appropriate services. And again, echoing WHO, calling specifically for research on the epidemiology of health needs. In other words, what are they? How much of a health need is there? In whom are they occurring? And how does that change over time? Again, if we don't understand the health problems in this population, we're not very well equipped to respond to them. So, as I mentioned before, I had the wonderful opportunity a couple of years ago to lead the health theme in the UN Global Study on children deprived of liberty. And within this very large study, our job was to do our best to answer two questions. And it was thinking about those two questions across all settings where children are deprived of liberty. So the UN Global Study estimated that in the year of the study occurred, 2019, there were 7.2 million children de facto deprived of liberty around the world. And you can see from the figure here that that's broken down into different groups. The green section of this chart with the number upside down, 330,000, is the conservative estimate of the number of children in migration-related detention around the world in 2019. And that number is likely, of course, increasing year on year. So the two questions that our group were tasked with answering as part of this global study were, firstly, what are the health needs of children deprived of liberty in different contexts? And secondly, what impact does deprivation of liberty have on the health of those children? Now, those two questions are important because we know from what I've already spoken about that children in immigration detention, for example, have a higher prevalence of mental health problems, and they often have poor outcomes after immigration detention. But that doesn't necessarily mean that immigration detention is causing those problems, because we know that many children come into immigration detention with pre-existing health issues. So those two questions, what are the health needs of children in detention? And secondly, what impact does detention have on the health of those children? So I've tried in this one slide to summarize all of the global evidence about probably the most significant issue for the health of children in immigration detention in particular, which is around mental illness, and a key marker of mental illness and poor mental health, which is self-harm. And again, I suspect that the people on this call are already aware that self-harm is a significant concern for people in immigration detention. So we know now from a growing amount of research around the world in multiple countries that in the context of high rates of mental health problems, there are also high rates of self-harm and suicidal behaviour among people in immigration detention. And there are really at least two aspects to that. The first is that immigration detention, as discussed, is a high-risk setting. It's high-risk setting because it's not a therapeutic place to be. It's a place where people are deprived of their liberty, often in non-therapeutic conditions. We know that uncertainty about processing, about how people are going to be treated in those settings, adversely impacts on mental health and increases the risk of self-harm. We also know that when decisions are made, determinations are made about asylum seekers, and if those decisions are negative, that can negatively impact on mental health and lead to self-harm. And we also know that family separation, particularly important, obviously, for children, can further compound mental health problems and precipitate self-harm. As I mentioned before, in addition to that, the people coming into immigration detention are arguably high-risk individuals for self-harm. Many people in immigration detention have experienced trauma, either before migration, for example, in the context of war, or during the migration journey itself. Many people have pre-existing mental health problems, substance use problems, which further compound those mental health problems. And all of that can be compounded by the social isolation associated with migration and immigration detention. So what do we do about all of that? Well, other things that we know that the rate of self-harm among people who are migrating is much lower in the community than in any type of detention. So there isn't really any good evidence that more restrictive detention is associated with higher rates of self-harm. What there is good evidence for is that people in the community have much lower rates of self-harm than people in detention. We also know that rates of self-harm increase with time spent in detention. The longer someone spends in immigration detention, the more likely they are to self-harm, the more frequently they will self-harm. So the evidence that we have about monitoring of self-harm, which is a significant issue, is not so good. But again, the evidence, such as it is, suggests that monitoring and reporting of self-harm in detention, according to WHO's guidelines, is inadequate. In other words, we're not monitoring this very significant health concern sufficiently in many contexts. So clearly, one thing we need to start thinking about is routine monitoring and reporting of mental health status and mental health related events such as self-harm in detention. So really, of the two questions that we were asked to answer in the global study, that's the easy one. We know that people, including children in immigration detention, often have very poor health, particularly poor mental health. The more complex question to answer is, what impact does immigration detention have on mental health? And I just want to share a couple of key reviews with you. This is a review published in 2009 in the British Journal of Psychiatry that looked at all of the evidence globally on the impact of immigration detention on mental health. So what they found is that the research was not very good at that stage. Bear in mind, this is 13 years ago. The area of research is in its infancy. Most of the studies were quite weak in terms of their research design. There was a consistent finding of high rates of mental health problems and some evidence of an impact, an adverse impact of detention on mental health. So that was the first review, 2009. This was updated 9 years later in 2018 in this updated systematic review in BMC Psychiatry, and it really built quite explicitly on the 2009 review. This study included 26 studies looking at over 2,000 people who'd been in immigration detention. And here's what they found. Of those 26 studies, they found that adults, adolescents, and children experienced high levels of mental health problems in immigration detention. As I said before, anxiety, depression, and post-traumatic stress disorder are the most common, both during and following release from detention. They found higher symptom scores in detained compared to non-detained refugees. And again, more clearly than in 2009, the longer people were in detention, the worse their mental health became. So that's strong evidence that detention makes mental health worse. And greater trauma exposure, not surprisingly, associated with worse mental health. So what they're really doing is saying we need to think about the mental health impacts of immigration detention. Again, you know, the researchers here, and I'm a researcher, are not trying to tell countries what to do with respect to immigration detention. What they are saying is that if you do detain asylum seekers, it's likely to have significant adverse mental health impacts. And there is a responsibility to try to minimize those mental health impacts as much as possible. Just lastly, there was another review published a few years ago specifically about the impact of immigration detention on child mental health and development. And building on the other reviews, a couple of key things they found. Firstly, in terms of the life course trajectories of children in immigration detention, parental separation in particular can threaten attachment bonds, which can have lifelong impacts on the mental health of children, not just on their relationship with their parent, but with their mental health and their capacity to relate in healthy ways to others. They also found good evidence that toxic stress, so chronic stress that children can experience in these contexts, can lead to inflammatory and autoimmune conditions, so chronic physical health problems caused by the stress of immigration detention. And they pointed to a couple of resilient factors, things that we can do about this. The first is to ensure that the children, in their view, are in a place where they feel safe and protected. Secondly, that children have access to culturally appropriate mental health services and age appropriate, obviously, mental health services. The third is that family reunification as early as possible is likely to lead to better outcomes, and that rapid assessment of asylum claims so that children can move on from that experience as quickly as possible, all associated with better mental health outcomes. So the evidence is getting stronger, and it supports what we concluded is the most likely situation in the review. We said it's not unreasonable to postulate that detaining a group of vulnerable children who have already experienced trauma and hardship will adversely impact their health and exacerbate existing mental health disorders. So clearly, from a mental health perspective, detaining children is not optimal. So what do we do about this? The UN Global Study on Children Deprived of Liberty took a life course perspective, and recognizing that deprivation of liberty, whether that's in immigration detention or any other setting, is a time-limited thing. People go into that setting and they come out of that setting. And if we take that broader view, there are a number of things that we can do here. The first is to increase access to health services and welfare services in the community, so that children don't find themselves moving towards places where they're deprived of liberty. This is perhaps less relevant to migration detention, but highly relevant to, for example, youth justice. The second is investment in diversion mechanisms, and this is relevant to children in immigration detention. So thinking about alternative mechanisms, alternatives to migration detention that both meet the needs of the country, but also meet the needs, notably including the mental health needs of the child. The third one I'll come back to in a moment is quality and continuity of care. In other words, ensuring that healthcare in detention is of an appropriate standard to meet the needs of these vulnerable children. And then the fourth recommendation was to ensure transitional support. So in other words, providing support for children not only during a period of immigration detention, but as they transition out into the community to ensure good health outcomes. And also, again, building the evidence base so that we know how to do that effectively and efficiently. So Manfred Novak, who was the independent expert who led the global study, said this: as migration-related detention can never be considered as a measure of last resort, I strongly urge states to stop all forms of immigration detention of children, whether unaccompanied or migrating with their families, and replace it by appropriate non-custodial solutions. So just finishing up on the global study, what were the key recommendations? The number one recommendation from the UN Global Study on Children Deprived of Liberty was to reduce the number of children in all places of detention, as you can see from the previous quote, notably including immigration detention. I've just pulled out a few of the recommendations. Number four, again, echoing WHO's advice and recognising the importance of a coordinated response across mental health, education, housing, and so on, is to ensure close interagency cooperation between all of the different government sectors and non-government sectors relevant to the well-being of children. And lastly, and I'll come back to this in a moment, I'm aware of time, that health services in all places of detention shall be of a standard equivalent to that available in the community at large. In other words, the quality of healthcare for children in detention should be at least at a standard the same as that would be available to them in the surrounding community. So there's sometimes a bit of concern about that. There has been a very strong international push to try to end the immigration detention for children, and in fact to end deprivation of liberty for children in all forms. But that doesn't and shouldn't and must not come at the expense of efforts to protect the well-being of children who are deprived of their liberty. In other words, it's entirely possible to, at the same time, make every effort to minimise and hopefully eventually eliminate deprivation of liberty for children, but at the same time ensure that while it continues to occur, while children continue to be in immigration detention, for example, ensuring that the healthcare they receive in that setting is appropriate to their needs. And in fact, failure to do that would amount to compounding health inequalities, making the health of the most disadvantaged and vulnerable children even worse. So I've mentioned before that a lot of my work has been around the health of people in criminal justice detention. And indeed, there are some similarities, some differences, but some important similarities and some lessons that can be learned. I just want to very quickly talk about this WHO policy brief. It's about 10 years old now, talking about governance for prison healthcare. And the key point from this document is to persuasively argue that healthcare in prisons should be delivered by a Ministry of Health and not by a Ministry of Justice. And so you can see the parallel that arguably healthcare in immigration detention should be delivered by a Ministry of Health. Having said that, WHO goes on to say the following: the management and coordination of all relevant agencies and resources contributing to the health and well-being of people in detention is a whole of government responsibility, not just a Ministry of Health, not just immigration detention, for example. But health ministries should provide and be accountable for healthcare services in places of detention and advocate healthy detention conditions, I'm paraphrasing. The reason that's important and relevant to immigration detention is that I would argue that border guards are not appropriate mental health care providers for a number of reasons. The first is role conflict. So border guards have a primary responsibility for security and good order and management. And that's not always compatible with providing therapeutic mental health care for people. The second, obviously, is that border guards aren't necessarily trained as mental health experts. In fact, I suspect usually are not. And that means that border guards typically are neither capable of identifying mental health problems nor capable of responding appropriately to those mental health problems. Now, that doesn't mean that border guards shouldn't receive training. Again, similar to what we see in the more progressive prison settings around the world, training border guards in basic mental health first aid, in identifying mental health problems and referring people to care is arguably an appropriate response. So I've got a very noisy slide here, and I don't intend to go through this, but I wanted to put it in on the assumption that these slides will be shared. Will these be shared with people after this presentation if they wish to look in more detail? I'm happy to send them to you as a PDF. I'll take that as a yes. So how do we mitigate the harms? How do we reduce the harms of immigration detention? Here, again, from the technical guidance from WHO, there's a large number of recommendations. I just want to draw your attention to a few of them. The first is to think about healthy policies. So using alternatives to detention and avoiding immigration detention wherever possible, prohibiting the immigration detention for children entirely, and strengthening health and support systems to meet the often complex and acute health needs of people who are migrating from one country to another. For people in immigration detention, avoiding prison-like characteristics. So noting again that people are not sent to immigration detention to be punished. They are being deprived of their liberty and not deprived of their right to health. And that includes, among other things, an adequate number of staff with clear roles, going back to this issue of border guards providing security, health staff providing health services. To make sure that there is sufficient resourcing, making sure that non-government organisations and other relevant agencies have access to those settings to provide services. And in terms of the personal skills of staff working there, timely skill development, including first aid, cultural competency and so on is important. And then, of course, the things I've spoken about before about how to provide appropriate healthcare in those settings. I won't repeat them again because the point is that these, again, echo the recommendations from WHO, from the World Psychiatric Association, from the UN Global Study, and so on. So I know I'm running out of time, but I also just wanted to share with you this way of thinking about these issues. This is from a technical guidance that WHO has produced around the health of refugee and migrant children, where they're recognizing, again, this idea that immigration detention is a setting through which people pass. There's a period of time before migration, during the journey and in immigration detention, and then a time in the country of destination. And if we're interested in achieving the best health outcomes for those people, we need to think about what can be done in each of those settings before migration, during the journey, and in the country of destination. So we know that there's often very little we can do to prevent people who are migrating from being exposed to diseases, to violence, food insecurity, poor healthcare, and so on. And often people are trying to go to another country in the hope of achieving better healthcare. During the journey, there's a great deal of risks I'm sure people are aware of, and we must be careful not to compound those by the circumstances in immigration detention. And then once people are in their country of destination, particularly people released from immigration detention into that country, we need to think about care after release from detention, about culturally appropriate care, ensuring access to health services that are culturally appropriate, age appropriate, and so on. So WHO recommends 2 health promotion strategies for people, the health of migrant children. The first is ensuring access to equitable care and education being a key driver of health outcomes for children and adolescents. And secondly, ensuring individualized health assessments, not making any assumptions about the health needs of children who are migrating. In addition, WHO recommends 3 public health strategies. The first, and again, this echoes something that's been said many times now, intersectoral collaboration between health, migration services, housing, education, employment, and so on. Avoiding detention of migrant children and ensuring a holistic age assessment, because we know that we're not actually very good at determining the age of children in the absence of documentation. I know I'm nearly out of time. I just wanted to draw your attention to this document from the Global Detention Project, just thinking about some key considerations for mental health care in immigration detention. This report identifies 11 key issues. The ones I wanted to draw your particular attention to are these. They talk about the importance, again, of interagency communication, but at the same time, what they call role differentiation. In other words, border guards provide security, health staff provide health. So working together, but with clear lines around who's responsible for what. Thinking about a staffing model, which is difficult because not everybody in immigration detention is the same, and the health needs of children in those settings are likely to be very different from those of adults, and that needs to be taken into account. Clinicians working in that setting need to be authorized to work in that setting, but at the same time have clinical independence. In other words, their responsibility is to provide care, not to provide security in any way. And also just talking about the clinical complexities of detention and what the Global Detention Project describes as an invalidating environment. So in other words, arguing that detention is fundamentally incompatible with good mental health. So just lastly then, I just want to very quickly summarize some of the key points from the WHO's policy brief on health concerns among children deprived of liberty. And this really builds on everything I've spoken about so far. And there are a couple of key concepts that I want to draw your attention to. The first is that WHO takes what's called an ecological framework. So in other words, if we're thinking about the health of a child deprived of liberty, we don't just think about that individual. We need to think about their relationships that they have. We need to think about the community within which they live, and we need to think about the broader structural and social determinants of health, within which all of that sits. So it's like the layers of an onion. And thinking about the health of children deprived of liberty requires that we think at all of those different levels. The second concept that you can see from this figure is that WHO is very clearly taking a life course perspective. In other words, again, recognizing that deprivation of liberty is usually quite a brief experience that children have as part of their life journey. We know that it's typically the most disadvantaged, unwell, and marginalized children who are deprived of liberty in all contexts. And therefore, what we do to improve or worsen their long-term health is an important part of our response to reducing health inequalities. And in each of those settings, the time before deprivation of liberty, the time during deprivation of liberty, and the time after deprivation of liberty, we need to think about the harms and trauma that are associated with those experiences, the trauma of war, the distress caused by detention, the stress caused by being released into a community where you don't feel you belong, coupled with the pre-existing vulnerability of children in those contexts. Again, noting high rates of mental health problems, high rates of self-harm, high rates of co-occurring substance use issues, communicable disease issues. So just in finishing, what are WHO's key policy actions and recommendations in light of all of this evidence? The first is that WHO notes that from a public health perspective, that attributes particular weight to health equity and the importance of early life conditions for future health and well-being, it's difficult to imagine a more damaging situation than depriving children of their liberty. It's clearly not something that we would do if our only priority was the health and well-being of children. Given that, WHO recommends the abolition of all justice and migration-related measures that result in children being deprived of their liberty, and consistent with the UN Global Study, recommends that that has at least three parts. The first is upstream prevention, so addressing the causes of children ending up in places where they're deprived of liberty, whether that's in immigration detention or other settings. The second is diversion for children who are coming up against that system into more appropriate, non-custodial, non-detention alternatives. And the third is deinstitutionalization, so working to dismantle the institutions that permit depriving children of liberty in these settings. WHO also recommends health protection and promotion within detention facilities, again recognizing that protecting the health of children in detention is not incompatible with preventing detention. Both can occur. So noting that children in immigration detention and in any other setting where they're deprived of liberty retain their right to the highest attainable standard of health. Noting what's often referred to as the principle of equivalence, which means that given that the burden of health problems in detention is much higher than in the surrounding communities, the volume of health services in detention must also be higher than in surrounding communities to achieve equivalence. The third thing in the context of the pandemic that WHO notes is that COVID-19 can further compound the mental health risks associated with deprivation of liberty, particularly where we have quarantine and isolation procedures that don't simultaneously try to reduce the mental health harms associated with isolation. Again, consistent with everything I've been saying, WHO recommends appropriate follow-up after detention, and that includes release planning for children being released from immigration detention, transitional care, supporting children and their families returning to the community, and reintegration support and assistance to ensure that people aren't just released to the community, but integrated into that community, supported to seek appropriate housing, social networks, meaningful activities, education, employment, and so on. And lastly, WHO recommends that we do need to still improve the evidence base. We still don't know enough about the health status of children in detention, including in immigration detention. We know even less about the scope, quality, and effectiveness of healthcare in places where children are deprived of liberty. And we know almost nothing about the health social or criminal justice outcomes, for that matter, of children after release from detention, whether that's immigration detention or any other setting where they're deprived of liberty. And while ensuring that the voices of children who experience deprivation of liberty are given priority, WHO is effectively saying what gets counted gets done. And of course, we therefore need to start counting these problems to solve them. Thank you.